So, hi everyone, and welcome to the ninth TIA Centre seminar of the academic year. So, for those of you that are new to our seminars, we like to invite leaders in computational pathology and related areas to give talks about their research. And today, we're absolutely delighted to be joined by Dr. Matthew Pugh. And the title of Matthew's talk today is Multiomic, Spatial Profiling and AI, Next Generation in Diagnostic Haematopathology. So Dr. Pugh is an associate clinical professor and an honorary consultant haematopathologist based at the University of Birmingham, following a BRC molecular pathway fellowship at the ICR in London and JSPS and BHP predoctoral fellowships. He was awarded an MRC CRTF, and Dr. Pugh now leads a group researching EBV-driven lymphoproliferations, specializing in the use of spatial profiling techniques to transform our understanding of lymphoproliferative disorders, improve diagnosis, and improve treatment. So thank you very much for joining us today. And we look forward to your talk.
It's a pleasure. Thank you very much. So apologies for the late start, but I'm really grateful for the opportunity to present to you today. So as you would have gleaned from the introduction, I'm not a computational pathologist per se. I'm a haematopathologist, which means that I diagnose blood cancer essentially using tissue biopsies, both bone marrow and lymph node biopsy. And essentially, what we've done in pathology, as you well know, hasn't changed really for 100 years. And what we've done in terms of immunohistochemistry hasn't changed for the past 30 years. And I think it's time now we can finally, start to think about upgrading what we do, first through the use of multiomic tissue assessment technologies, and then integrating that with computational analysis. So, I guess there's lots of proposed models for how computational pathology and artificial intelligence will aid diagnosis and pathological diagnosis. And there's lots of models in development at the moment. Some focus solely on the H&E, others integrating more broader sort of multi-omic technology, and possibly using H&Es to generate pseudo IHCs. But what I want to give to you today is my opinion as a diagnostician of how AI and computational pathology can best help us, I think, and that's obviously for debate as well. And happy to have some discussion around that in terms of how other people think it can best benefit us. But these are my views, I think, on how this combination of technology and computer science can help us, certainly in the diagnostic realm. Okay, so diagnosing blood cancer is essentially a complex business, probably I think a little bit more complex than other areas of diagnosis. We have to integrate data from various modalities in order to render a diagnosis. So, the clinical picture is really important from us. So one histological picture can equate to lots of different clinical pictures, and different outcomes for the patient. We also have to integrate what's going on in the blood, what's going on in the tissue, and there's lots of different tests then we can employ on the blood and tissue, from simple cell type counting through to immunohistochemistry and advanced molecular diagnosis. But the final diagnosis is an integration of all these modalities. And the gold standard now as haematopathologists is that we integrate all these modalities to make a final report, rather than issuing a single report just on the histology or just the immunohistochemistry. The gold standard, as recommended by the Royal College of Pathology, is that we integrate all the findings to form a final report. And that's the safest thing to do for the patient. Now, the other thing that's unique, I think, to haematopathology, and that's different from many other areas of histopathology, is that we're wholly dependent on immunohistochemistry. I think any pathologist who's worth his salt could render a diagnosis of colorectal cancer simply on the H&E, and that's not an issue. But when it comes to haematopathology, and these are malignancies of lymphocytes predominantly, we still can't tell the difference most of the time between a malignant and a reactive lymphocyte. And then, furthermore, we can't tell the difference between a B cell and a T cell and the CD4 cell and the CD8 cell. To us, to the human eye, they all look the same. So immunohistochemistry is vital, in order for us to subtype these tumors and even sort of render whether this is a benign or a malignant process as well. Now, of course, we do use some architectural features to help us make that distinction. And sometimes, the size of the lymphocyte is important. aggressive lymphomas tend to be bigger, low-grade lymphomas tend to be smaller, but nonetheless, we can't usually go much further than that without immunohistochemistry. The way we do things at the moment is quite inefficient as well. Okay, so it's really iterative in the sense that we look at the H&E, we formulate a hypothesis in terms of what are the differential diagnosis. So we might say, there's a list of 3 or 4 lymphomas this could be, and then we order a panel of immunohistochemistry. Then we look at the immunohistochemistry, and this might be a day or 3 or 4 days later, and then we'll either render a diagnosis or we'll say we need more immunohistochemistry, which will be another delay of 2 to 3 to 4 days, and then hopefully we can eventually make a diagnosis. But it's iterative and it's inefficient at present. The other thing, it largely depends on the skill of the pathologist as well to select the right markers, and every investigation is very bespoke and individualized for each patient. And whenever something is bespoke and individualized, it's inefficient essentially, okay? Because the lab has to cut sections, for these specific markers, run a specific constellation of tests for any given patient as well. And it's prone to error. So a pathologist might look at this H&E here and formulate a hypothesis that this is a Hodgkin lymphoma, or order the Hodgkin lymphoma markers, CD30, PAX5, and then render a diagnosis of Hodgkin lymphoma. However, if the pathologist was to omit an ALK1, they might miss that this is an anaplastic large cell lymphoma. Now, what this means, these are two totally different lymphomas. One's very aggressive, one is only moderately sort of aggressive, but they need different treatments as well. And just missing out one marker from that panel can completely change the face of the diagnosis as well. Okay, so as you can imagine, whenever you've got a step which depends on a human having to select the right marker, it's inevitable that errors will get made, okay? And this just highlights the inefficiency of the process. Essentially, the tissue has to go back and forth to the lab several times. There's multiple immunohistochemical tests. So presently, they're all done on separate slides chromogenically, okay? So lots of different tests, which brings in its own problems as well. One of the problems with doing all these tests on separate tissue sections is that it can exhaust the tissue, okay? So as we start off with a nice full face as we got in section 1, and as we order all these different immunohistochemistries, we exhaust the tissue. So this could mean that we have an incomplete diagnosis. We can't do further molecular tests, which might be vital for the patient as well. And, that could then expose the patient to further risk if they got to go back for a re-biopsy. They might need an operation to get more tissue. And so it all adds more costs to the patient and exposes them to more risks as well. The other issue as well with performing the test on separate slides is that interpretation is difficult, okay? So this image here, those blue dots represent the Epstein-Barr virus. Now, this could be a number of different lymphoproliferations. It could be something called chronic active EBV, in which you get Epstein-Barr virus in T cells, or it could be something like infectious mononucleosis or some other B-cell lymphoproliferations in which you get a virus in the B cells. So at the moment, the challenge of the pathologist is trying to determine, are those blue dots, are they in the T cells or the B cells in order to render the diagnosis? And of course, when you look at a separate test, it's really difficult. And you can see, I think it's really difficult to pick out which population of cells that virus is in. Whereas if you've got a multiplex image, then potentially all the markers is much easier to interpret. Now, the other thing as well, haematopathology is a specialist practice, okay? Not every small hospital will have a haematopathologist. It tends to get practice in large centres. So I'm using Wales as an example here. Most of the haematopathology diagnosis happens in the south here in the large diagnostic centre. So if somebody's got a suspected lymphoma in North Wales, the tissue will have to be sent by post, usually down to the centre in the south there, which again is inefficient, causes delays, and introduces a degree of health inequality as well. If you're a patient who lives in Cardiff or Swansea, you're going to get your diagnosis turned around quicker than somebody who lives in North Wales, just by virtue of the fact that the tissue has to be sent down by post, essentially. Okay. So what we are proposing to do, and what we are proposing is the next generation of diagnosis here is a multiplex immunohistochemical panel. But not just any multiplex immunohistochemical panel. What we're proposing is a comprehensive multiplex immunohistochemical panel, which comprises all the stains needed to make a diagnosis upfront, okay? Now, I'll just tell you very briefly before I go into the panel how the technology works. So we're using a platform called Comet, okay? So this does the immunohistochemical stain. So you stain with your antibodies, you image, you will then elute those antibodies away, and then you do another set of staining as well. And you can do this, for up to 80, 90, 100 markers, okay? And what you generate then is these multi-image TIFFs, okay, which you can overlay and then infer co-expression of markers from individual cells. So instead of having this panel-based approach, now what I'm proposing that we do is we can, encapsulate all the markers you could possibly need to make a diagnosis and do them upfront, okay? So instead of the pathologist looking at the H&E, deciding they want X, Y, and Z in a bespoke fashion, you just do the panel at the start before the pathologist has even seen the H&E. So again, this introduces a degree of efficiency to the system. So what would happen, the tissue comes to the lab, suspected lymphoma, they cut one or two sections, maybe one section for the H&E, one section for the immunohistochemistry. It runs through the lab. Every bit of tissue or every suspected lymphoma diagnosis is treated in exactly the same way. And then the first time the pathologist sits down, they can make a comprehensive assessment and sign the case out on the first day. So there's no need for iterative rounds of immunohistochemistry. Everything is done upfront. Now, if we revisit that problem we had earlier on, where we were trying to assess where the co-expression of the virus is in the B cells and the T cells, you can see from this multiplexed image that it's super easy to see that those red virally infected cells are in the yellow B cells there, okay? So you can see the yellow membranous marker and the red viral marker are clearly co-expressed in the B cell. So it's really easy to interpret, okay? So it reduces the risk of diagnostic error. Obviously, the other major advantage, these are digitized images that we're generating on the Comet platform. So there's no need to scan the slides. It's the platform encapsulates a microscope, and it just digitally records the image as you do the staining, as you do the sequential staining. And of course, this is much more amenable to quantitative analysis. Now, in hematopathology, we do lots of really basic kinds of things. So, for example, the distinction between what we call a pre-myeloma or an MGUS and multiple myeloma is 10% plasma cells in the bone marrow. So you can imagine we're having to count plasma cells at the moment to determine whether something is a myeloma or not. And, that's obviously time consuming, it's prone to error, because we're not going to count the entire slide, we're going to pick an area, and that area might not be representative of the wider slide. You get variations in plasma cells. Similarly, acute myeloid leukemia, a really aggressive malignancy, the cutoff is 20% blasts in the bone marrow, similar situation there. And so, feasibly, you could get a different diagnosis depending on which centre or which pathologist reviews your pathology that day, and depending on which area of the slide they decide to make their counter. Naturally, if we had quantitative analysis that could quantitate the blasts for the entire slide, that would make that far more reliable, far more reproducible, and much quicker for the pathologist as well. It also helps with equitable healthcare access, because we could put one of these machines in North Wales, going back to our example earlier on, and if they got a suspected lymphoma there, they can just run this assay. There's no need for any specialist training, because the assay will be pre-packaged. It does all the markers you need to diagnose, and instead of sending the tissue down south, data can be sent down south to the specialist hematopathologist, who can then review the case almost instantly. Okay, so it reduces the inequalities in time to diagnosis as well. So what are the barriers to adoption at the moment? So there's no CE-IVD accredited platforms for high multiplex immunohistochemistry at the moment. There's no robust control protocols. Everyone knows when you do a chromogenic singleplex immunohistochemical stain that you need to have a decent tissue, positive and negative control, but people seem to forget that when they do multiplex stains. And there's no good user interfaces specifically designed for pathologists really to review these types of images. And the final major hurdle, I think, is this true of any new technologies, just getting these things adopted into the NHS as well. So what have we done? We've partnered with Lunaphore Biotechny, who manufacture the Comet platform. They've made a commitment to get this platform CE-IVD accredited, and they're going through that process now. We've also got a small grant from the MRC just to work up the panel, just to demonstrate ask the very basic question: can pathologists make a diagnosis on multiplex images? Because I know that sounds like a super basic question, but actually there's no precedent in the literature for testing whether hematopathologists can render a diagnosis on multiplex images in the same way that they can a chromogenic image. The other thing that we've done as well, of course, is we've partnered with Dr. Shan Raza, who's sat here as well, who's going to be looking after the computational side of the analysis for us as well. So in this initial small grant, the first thing we want to do is just ask, can the staining, can it recapitulate what we do currently with chromogenic stains to the same standard? And the answer is yes. This is an example stain here of a kappa stain, which stains a subset of plasma cells. And you can see that's the fluorescent image there on the right side. And it looks as specific, as sensitive as the gold standard chromogenic stains. And of course, the beauty is that we can then multiplex that stain essentially and show up other stains the same time as well to aid the diagnostic assessment. So this is an example of a complex lesion. This is a primary cutaneous marginal zone lymphoma. So in the primary cutaneous marginal zone lymphoma, you get lots of heterogeneous cell populations. You get B cells, you get T cells. And you can see, the multiplex stains helps you appreciate the architecture there. So the green cells, the B cells, you can see they're quite compartmentalized and they're quite separate from the T cells, which is sort of typical of a marginal zone lymphoma. But the crucial thing here for rendering a diagnosis, you can see the white nucleated cells. So that's MUM1 highlighting plasma cells on the periphery of these red and green B and T cells, where they are plasma cells, and they're only expressing lambda, okay, the blue stain, and they're not expressing any kappa. So that means they are monotypic, and monotypic is essentially a surrogate marker for a clonal population. Okay, so if this was a reactive plasma cell population, we'd see a mix of purple and blue cells, but we're only seeing blue cells, which indicates to us that this is actually a monoclonal population. Okay, so you can see there how viewing it in multiplex gives you all this rich information, rich architectural information, and enables us to assess definitively that we've got a clonal population and render a diagnosis of marginal zone lymphoma. The other area where this is super, super helpful as well is Hodgkinoid lymphoproliferation. So this is a real interest of mine. So what I mean by Hodgkinoid is that it looks like Hodgkin lymphoma. And the thing that's unique about Hodgkin lymphoma, the tumor cells are actually really rare, okay? Most of the cells in the tumor microenvironment are just reactive cells, and you get these rare lesional tumor cells, which can account for only 5% of the total nucleated cells. And what the pathologist really needs to do is to look which markers are co-expressed in those rare lesional cells, okay? And so what multiplex immunohistochemistry allows us to do is really hone in on those rare populations, okay? So it's just this large cell here, and see which markers are being co-expressed there. So you can say there's co-expression of EBA, which is a viral marker, and CD30 as well, which is a hallmark of Hodgkin lymphoma. And there's other sort of complex, I won't go into too much detail and labor the point too much, but there's other complex lymphomas as well, where assessing co-expression is really beneficial to a pathologist. And these multiplex images allows us to do that definitively. So obviously, we've got an image, we can turn the markers on and off at will, whichever markers we want. And, this is super beneficial for a pathologist who want to understand in depth the architecture of these lesions as well. So the next stage then, we worked up the panel, which we thought was equivalent, or we assessed to be equivalent to the chromogenic stains. And we just wanted to ask these questions: can pathologists render a diagnosis on these images? Because one would think that, okay, those multiplex images are giving you lots of information, but pathologists are just not used to looking at those fluorescent images. Okay, so what we did, we took a number of cases, we stained 15 lymphomas, and then we asked 5 pathologists to assess these 15 cases, and we wanted to determine whether they could render the right diagnosis. So in those 75 interactions with the 5 pathologists, they rendered the correct diagnosis, or the concordant diagnosis, in all interactions, okay, 100% of interactions. And in terms of the interpretability of the various stains, they found it equivalent in just under half and superior in just over half of those interactions as well. And where they found it superior, it tended to be in cases where you've got rare lesional cells, and it's much easier to assess co-expression in those cases as well. So what are our next steps now? So we've just literally just been awarded 250,000 by CRUK Horizons to take this to the next level. And the next stage now is to incorporate every single marker that we need for diagnosis. And this would include both RNA markers and protein markers. We want to develop the control protocol. Now, as I mentioned earlier on, we've got a control for potentially between 60 and 80 markers simultaneously. So the way we do that presently for single markers, we put a bit of tissue on the slide, which we know expresses a given marker, and we know was negative for a marker as well. But this might not be feasible when you're looking at 60 to 80 markers. So what we're doing, we're going to grow up some cell lines, and those cell lines will variably express the markers in the panel, okay? And then we're going to mix those cell lines up, pellet them, and turn them into an FFP tissue block, okay? So we'll have cells which individually express or don't express the markers in the panel, almost like a barcode, if you like. And then we're going to section that pellet onto the slide, and it'll only take up about 1 or 2 millimeters space on the slide, and that would enable us to control for every single marker that's in the panel as well. And this is where Sian's work will come in now. I mean, what really excites us, I mean, essentially what we've done up till now is recapitulate what we've done on the chromogenic stains. But what the exciting bit, I think, is what we can't currently do on the chromogenic markers. So the first thing really is the directed analyses. So just being able to enumerate different cell populations, you know, are there aberrant populations, for example, what are the distribution of those populations? What's the blast count? What's the plasma cell count? So those very basic directed analyses, which we're currently doing manually, can we digitize them, make them instantaneous, and aid the pathologist's diagnosis as well? Then I already mentioned to you the pathologists really struggle with looking at fluorescent images. So we're going to use obviously generative AI to recapitulate some of the tinctorial stains, so the pseudo-DAB, but also the H&E, the Giemsa, the reticulin, all the tinctorial stains that we use to aid diagnosis. We're going to use the fluorescent images to recapitulate those stains as well, to aid pathologist distinction. And finally, a longer term goal then will of course be the sort of predictive AI, either to predict diagnosis or to predict outcome as well for individual patients as well. Now, in some sense, predicting diagnosis perhaps is it'd be super cool, but maybe the least useful thing we do, at least in the short to medium term, because I mean, I feel that people will still want a human in the loop for this aspect. You know, in the same way that you can have an autopilot fly a plane across the Atlantic, people still put a pilot in the cockpit as well for when things go wrong. And we've done some research around patient attitudes on this, and patients still want a human making the final call. So the AI could maybe tell us this is 95% going to be a follicular lymphoma, but having the pathologist interrogate the data and confirm that is the case, I think will be important for some time to come as well. But I think there still will be exciting prospects in terms of AI predicting treatment response and outcome, and that's things that we can't, maybe reliably do, that the AI will do, maybe probably better than we can do as pathologists as well. Now, I think a really basic but important aspect of this as well is the pathologist user interface. Okay, so it kind of seems maybe not so, user interface is not exciting stuff, but it's super important, and will really lead to huge gains in terms of efficiency. Now, as I mentioned at the start, we have to integrate lots of data, the blood counts, the flow cytometry results, the genetic results, the immunohistochemistry, the IHC, in order to render a final diagnosis. And practically what this means is that I'm opening lots of different programs at the moment. I'm opening one program to look at blood results, another program to look at the flow cytometry. So what I'd really like is a user interface that incorporates all these aspects, okay, into one package that I can easily pull out. Something that maybe highlights the patient's hemoglobin has dropped over time and shows me a graph that I can then integrate into a report and say, look, this patient's got a drop in hemoglobin that's dropped over the past 2 years. the morphology is consistent with an NDS, and my final diagnosis is MDS. So these are all efficiency gains that I think AI in the computational side of things can bring to our diagnostic practice, which in the short term, which I think is probably more important than helping us with the diagnosis. And beyond just bringing in these pathological aspects like the blood counts, what I want this to integrate is the clinical aspect. So how did the patient present? So for example, if you've got a patient with night sweats, mediastinal lymphadenopathy, so they got enlarged lymph nodes in their chest, there's a good chance, even before we've looked at the pathology, this is going to be a Hodgkin lymphoma, for example. So what we want is multimodal data sets, okay? And we're going to start consenting patients not only to use their tissue, but to use the clinical data in order to help us render the diagnosis, predict prognosis, and predict therapeutic response as well. And you can envisage as well that possibly the AI will start to help then identifying which patients actually need a biopsy as well. And we could even start to employ some of this AI in GP practices. If patients got a particular constellation of symptomology and blood results, then maybe that might be able to flag up that they actually need to go for biopsy as well. Okay. Now, you may have picked up that what I'm proposing to do is actually quite wasteful in a sense, okay? Because at the moment, we only employ a limited panel of immunohistochemistry. Now I'm saying we do every immunohistochemistry in every case, okay? Which, financially, does that make sense? So we've done some health economics on this, okay, based on our centre at the Queen Elizabeth Hospital, which is a large throughput centre. And what we factored in to do the comprehensive testing is more per test, and that would lose £26,000 a month almost, okay, in additional testing. However, there are efficiency gains as well, okay? So if you only compare test to test, it costs more. But you obviously save in lab efficiency because they haven't got complex bespoke investigations anymore. They just cut one section for every patient and they don't have to worry about what tests they're ordering. Pathologist time is reduced. Instead of assessing the case across 3 different days over the course of 2 weeks, we sit down once and we diagnose that case first time. So it almost sort of cuts the time down that we spend with the case by 1/3 almost. Okay, there's administrative costs then. And then there's wider costs. So it actually costs the healthcare system, okay, to keep a patient in the system for longer, okay? So the longer they spend waiting for the diagnosis, it could mean additional hospital beds, it could mean time off work for the patient whilst they're waiting for the results as well. That costs money. And also we reduce on repeat biopsies, okay? So a repeat biopsy is super expensive. And for them to come back in, they might need an anaesthetist, they might need a surgeon, depending on the location of the additional biopsy as well. That's further expense that we're saving. And what we haven't costed in to this as well is that we think it'll reduce error as well. And of course, one diagnostic error can cost a trust upwards of £1 million as well. Okay, but we haven't factored that in yet. But just factor in those basic efficiencies, which are predictable, which I've mentioned there, then that would actually save, even accounting for that loss of £26,000 a month, it would save the trust about £500,000 a year as well. So it's more efficient to do more upfront, okay? Data upfront, at least in this scenario, is more efficient than this iterative system as well. The grander vision as well is that I want to incorporate spatial transcriptomics into this as well. Now, we wouldn't have to do spatial transcriptomics on every single case, okay? But there are cases which, despite throwing all our best technology at, we still can't decide on a diagnosis. These edge cases, okay, they're rare, but they're significant, and we can't decide if it's a follicular lymphoma or a marginal zone lymphoma. And these are treatment-defining decisions as well, okay? So what I want to do is to run large numbers of cases using these single-cell whole transcriptome, spatial transcriptomic techniques in the hope that we can start to decipher between one or another diagnosis in these edge cases. And I'd like to make Birmingham a centre for that we run large number of cases so that when the centre, for example, in London or Scotland, comes across a difficult case, they can send it to us and we've already done the work to enable them to make a diagnosis. Another beautiful side effect as well of doing this seemingly wasteful work and applying tons of markers for every single case is that we generate these high-dimensional data sets, which then can be utilized for discovery and translational science as well. So, for example, follicular lymphoma is a B-cell lymphoma, okay? But we're going to do a load of T-cell markers, which are not necessary for the diagnosis, but they will characterize the immune microenvironment in some detail. So we'll have a broad bank, a data bank of cases of follicular lymphoma, in which we've done a load of T-cell markers, which someone who's interested in follicular lymphoma can then take away and use for discovery science as well. So it'll be a very nice side effect as well. Now, I'm just going to finish off by giving you an insight sort of how these technologies help in one very focused field of diagnosis, which is my area of interest, which is Epstein-Barr virus-driven lymphoproliferation. How am I for time? Yeah, I'm all good for time. Okay. So this is my research interest, and we've done lots of multiplexing and lots of spatial transcriptomics on these lesions as well, okay? And I think this is the most difficult area of diagnosis. And if it can help with this area of diagnosis, then I can convince these techniques will help with absolutely any area of diagnosis. Now, the Epstein-Barr virus is a really interesting virus, okay? It's the most oncogenic virus ever described. It's a cancer-causing virus, okay? And what it does, if you incubate the virus in a test tube with B lymphocytes, okay, immune cells, it turns those cells cancerous, okay? The only thing that stops it to turning our own B cells cancerous is the T cells in our own body. Okay, our own T cells keeps the Epstein-Barr virus under control, and most people in this room will be infected with Epstein-Barr virus. So it infects over 90% of the population. You'll know it more commonly from glandular fever or the kissing disease or infectious mononucleosis, okay? So most people are infected in childhood or adolescence. It causes glandular fever, and then it remains dormant in our B cells for the rest of our life as well. But in a subset of patients, that virus becomes reactivated, and it can cause a number of blood cancers, including Hodgkin lymphoma, diffuse large B-cell lymphoma, and a load of other lymphoproliferations as well. So I'm really interested in the virus, and it's really diagnostically challenging as well, because it results in a number of different lymphoproliferations and lymphomas. And from a pathological point of view, when we look at these under the microscope, they all look the same, okay? They all look like Hodgkin lymphoma. But they don't all behave like Hodgkin lymphoma. Some behave really in a benign, indolent fashion, and they don't need any treatment whatsoever. And some behave in a really aggressive fashion. So you've got these lesions here called Epstein-Barr virus mucocutaneous ulcer. They look like Hodgkin lymphoma under the microscope, but we need to recognize them because they don't need any treatment, okay? If you leave them alone, they go away. Then you've got Hodgkin lymphoma, which is the archetypal example of a Hodgkinoid lesion, which is a malignancy, okay? But it actually responds quite well to therapy. 90% of patients will be cured of the disease. And then you've got these really aggressive lymphomas, again, look like Hodgkin lymphoma, but actually they're super, super aggressive, and they need aggressive chemoimmunotherapy in order to respond, okay? And so basically there's a dearth of reliable markers that enable us to distinguish between these lymphoproliferations. So what we did, we done multiplex immunohistochemistry on these lesions. We've done spatial transcriptomics in order to see if there's something that we are not seeing as pathologists when we looked under the microscope. Are there patterns in terms of the immune cells or the transcriptomic profiles of these lesions, which help us distinguish what's going on. So what we did, first we did multiplex immunohistochemistry. We then phenotyped the cells by clustering. So we looked at which constellation of markers were co-expressed, and we used that then to infer different phenotypes. So you can see the various phenotypes here, M1, M2 macrophages, CD4, CD8 T cells, etc. And then we used that then to render a digital simulation of the tumor, if you like, okay? We then compared these digital tumors across the three entities, and we looked at the various cell abundances then across the different entities. So there's lots of data here. But I mean, in the first instance, when I looked at this, I kind of felt vindicated for not being able to differentiate these lesions, because actually the cell populations were quite similar across all three lesions. There was very few statistically significant differences in terms of the cell populations, okay? But one thing did stand out with these M2 macrophages, okay? So within the tumor microenvironment, macrophages can take on different flavors. They can be pro-inflammatory, in which they encourage an immune response, or they can be reparative, in which they're trying to repair tissue, essentially, okay? And interestingly, in these benign lesions, we saw fewer M2 macrophages, whereas in the malignant lesions, such as EBV positive diffuse large B-cell lymphoma, that's the aggressive one that I told you about, we got lots of these reparative type macrophages, okay? So the implication here is that the macrophages in the aggressive lesion is dampening down the immune response, okay, which biologically makes sense, okay? So what the immune system should be doing is coming in and clearing the virus and clearing those tumor cells. But what is not doing here is actually the macrophages are kind of aiding and abetting the virus and dampening down the immune response because they're enriched for these M2 macrophages, okay? Similarly, when we dissected those M2 macrophages further, we saw expression of other markers as well, which also leads to dampening down of the immune response. So IDO1, for example, is a checkpoint, okay, which dampens down the immune response. And that was also enriched in these aggressive diffuse large B-cell lymphomas. At the other end of the spectrum then, where we looked at the EBV mucocutaneous cells, so that's these benign friendly lesions, if you like, okay, which never progress, providing, won't cause you any harm as long as you leave them alone. They were enriched for M1 macrophages, so these pro-inflammatory macrophages, okay? And again, that makes sense because I guess that's the immune system doing their job. They're coming in, mopping up the virus, which is infecting the tumor cells and getting rid of the lesion as well. So it's a much more unfriendly microenvironment for those tumor cells to be in terms of the mucocutaneous cells, whereas the microenvironment is much more tumor friendly for those aggressive lesions as well. And the other thing, this provides us not only with potentially a diagnostic target, we could look for differences in M1 and M2 macrophages, but also a therapeutic target, because IDO1 is the subject of new therapeutics as well, new checkpoint inhibitors for EBV DLBCL. The next thing we did as well was characterize the transcriptomic microenvironment. So which genes are turned on and off in the immune microenvironment of these lesions. Now, before we did the spatial transcriptomics, we did have a quick look by bulk sequencing. Now, the issue with doing bulk sequencing in these lesions is that, as I mentioned earlier, the tumor cells are rare, okay? So or when you do bulk sequencing, in which you take a bit of tissue, mush it up, and just sequence whatever RNA transcripts are present, you're mainly characterizing the immune microenvironment more than the lesional tumor cells themselves. When we done that, we did at least see some separation of these entities. So you can see on the PC2 axis there that the mucocutaneous ulcer did seem to cluster slightly differently from those malignant lesions at the top there, okay? And when we look specifically at the genes which were upregulated or downregulated in the benign versus the malignant entities, we saw upregulation of this IL-1RN response, okay? Now, IL-1RN is a surrogate marker for the inflammasome, okay? Now, and the inflammasome, again, it points to this pro-inflammatory microenvironment in these benign lesions, which seems to be lost from the malignant lesions, okay? So again, it's all pointing to the same picture that we saw with the multiplex immunohistochemistry. So next we moved on to spatial transcriptomics. So what we wanted to do then is look specifically in the tumor compartment and the macrophage compartment. And what we saw then, when we looked specifically at the tumor compartment and the macrophage compartment, that those three different entities actually clustered out quite nicely, okay? We were able to start to distinguish when we only focused on those rare tumor cells, okay, in the microenvironment, or on the macrophages. So the macrophages are the triangular points here in this diagram, and the tumor cells are the round dots there. And they're on different axes here. You can see they separate out there across the three entities, which was quite nice, okay? And I'm just going to briefly just mention quickly look into the biology there, again, it's a similar sort of story. Okay, we see lots of markers associated with a pro-inflammatory microenvironment in cutaneous ulcer, where an immunosuppressive type microenvironment was upregulated in those tumor cells. And similar as well when we did looked at the gene set enrichment analysis, again, upregulated those pro-inflammatory response. So one of the major defenses against viruses, for example, is type 1 interferon. Okay, so you can see the type 1 interferon responses was upregulated in that benign entity, okay, which suggests the immune system is still actually trying to get rid of the virus in those benign ones, whereas it's not trying to get rid of the virus in those malignant lesions. Okay, and again, that's opened up a therapeutic avenue, because what we're trying to do now is restore those interferon responses in those malignant entities as a therapeutic means. So essentially, just in this small diagnostic niche, this multiplex immunohistochemistry with some really basic targeted computational analyses, and this is not even using AI to do anything fancier, has basically started to, one, provide us with means of diagnostically differentiating these lesions, but also give us some biological insight as well, how we can differentially treat these malignant lesions. So that's the grand vision, essentially, how we hope to integrate these technologies, where we want to take, how I think computational pathology can best benefit haematopathology diagnosis. I'm happy to take any questions and get your views as well on how you think AI can potentially contribute diagnostically as well to haematopathology. Thanks very much.
Fantastic. Thank you very much, Matthew, for a really, really interesting seminar there. So yeah, let's open the floor to questions. Does anyone have any questions they'd like to, either online or in person, they'd like to start with?
I would like to ask, how are your views on storing this data? So we know that usually by itself is a large hassle to just store them over years. So in this type of cancer, how long do you have to store this data, and how can you store this humongous amount of data?
Yes, I mean that's an excellent question. I mean, it's quite a poignant question as well, because we've started to digitize at the Queen Elizabeth Hospital at the moment, and frustratingly, we are getting rid of our digitized images after 3 months, which is ludicrous, really, because I think one of the major benefits of being digitized is that you've got this permanent digital store that you can look back at previous cases and compare the previous biopsy to the current biopsy. So it really needs investment for the NHS really to think about digital storage. I mean, there are things we can use in the short term. I think there's the West Midlands data, data. Is it what's it called? Storage. Secure data that we can use, in this research phase. But it really needs the NHS to wake up and invest in digital storage. And if anything, storing the digital data is more useful than storing the slides. Really, we invest heavily in storing slides, but slides fade, the stains fade over time. They become cracked, they become lost. It'd be much better if they just had focused, invested more in digital storage than physical storage, in my view. But absolutely, it needs significant investment. Absolutely, yeah.
Okay, so are there any questions online?
No. I had a question about the health economic slide.
Yes.
So of course you gave us the slide where you said it's a bit more expensive if we do all these extra tests.
Yes.
But overall, we're going to save $500,000 a year, which is great. Which would be amazing.
Yeah.
I was wondering what your thoughts were. If we could, of course, if we didn't do those tests at all, we could do everything from just the H&E image in the first place, then you'd save more money.
Yeah. I mean, absolutely. So first, I mean, I think that's got to be robustly demonstrated that can be done. I know, I've seen the studies that show, really robust predictions can be done from H&E, and I've even seen studies where people predict the IHC. The trouble is, it needs to be demonstrated beyond all reasonable doubt that every marker is predicted 100% correctly, because one marker can change the face of diagnosis. It can change the treatment you give as well entirely. If CD19 is expressed or not, that influences whether a patient can receive CAR T therapy, for example, as well. So in some ways, you know, given that, for example, a CAR T therapy can cost, you know, hundreds of thousands of pounds per patient. I mean, doing multiplex immunohistochemistry is expensive, but it is only £500. Is it worth risking an inaccurate prediction for the sake of £500, for example? So there would be we need really robust validation to make sure that you can 100% predict that. And the trouble for me, I'm a little bit of a non-believer in there, only because I see patterns of expression immunohistochemically that I've never seen before. And to me, AI is good at predicting based on previous precedent. But if I'm seeing things that are completely unprecedented every day down the microscope, I don't know how the AI is going to cope with that. You know, in very predetermined scenarios, predefined scenarios, it can help. When it's faced with potentially anything that could come through, I don't know how well it's going to do. But, you know, if it can demonstrate it beyond all reasonable doubt, then possibly, and we may have a phased strategy where, you know, 60% of cases, we're happy to just render the diagnosis on the H&E, then a subset of cases that we progress to immunohistochemistry, and then a small set that we do spatial transcriptomics on. But I think in the first instance, I think we'll have to go through a period where we do everything on everything, and then we can start narrowing down then on which cases that we can do a limited set of assays. But, you know, I'm happy to be proven wrong if that's the case. The other thing as well, even if it can do it, I don't know how much you've dealt with pathologists, but they're really, really conservative with a small c as well. And introducing anything new to them, I think they'll need to be done in a graded fashion, you know, possibly a period where they can see the immunohistochemical stains to give them the confidence to switch to just a predictive H&E as well. But yeah.
Sure, thank you. I think
you mentioned about using multimodal data sets before you do the multiplex. Couldn't that be used as in addition to H&E, as a kind of a triage before you do the whole set of panels?
It could be, yeah, it could be. And you could imagine even smart panels then, which adapt to the multimodal data set. For example, you know, the AI is deemed based on the radiology and the clinical data that this is 95% the Hodgkin lymphoma. So then, you know, the multiplex machine then does a more limited panel. It's just focused on those differentials. So that could be something. But I do think we'll need at least a period of doing everything and then hold it. But yeah, absolutely.
Buzz has. So we have a question from one of their pathologist colleagues, collaborators online. So Buzz.
Hi, thanks. It was a good talk. I was just wondering, from a health economics point of view, did you do any calculations on not necessarily health economic question, but the timings? In my department, money is one factor, but if we've got 3 immuno machines which can probably run, let's say, 60 tests a day or 80 tests a day, if you're about to do a battery of 25 to 30 immunos on every single case, it's not a question of money, because you can get many of the stains down to £1 a stain. It's actually the physical volume that you can't get through the lab. You would, if you did your practice within an NHS lab, and I would say internationally as well, it's not the money that's stopping us, it's the skilled labour staff and the machinery. So in some ways, as nice as it might be from a financial point of view, you would, behind your immuno workload would be stacked all the patients waiting P16 on cervical cancer diagnostics, all the head and neck cancers, all the melanoma markers. Like, you would actually saturate the diagnostic pathway, even if it was very little pay. I would be interested in seeing whether that would cause an issue, because all that additional savings that you could do by being selective, it's about continue.
Oh. So sorry.
Go ahead. I'm sorry. Carry on. You're about to say something.
I think you might have dropped out. Dropped out to the end. So yeah, I mean that's a great point. So this high multiplexing technology, I think has the most impact in haematopathology, only because on every single case, we're talking about doing about 20 immunostains on every single case. Okay, it'd be far less beneficial in diagnostic areas like head and neck, maybe where you're doing 1 or 2 stains. Okay, you may as well just stick to your chromogenic stains there. Now, if we go back to what you said about your immunohistochemistry machine, your current stain doing 80 slides, but that's 80 single-plex chromogenic slides. Now, you translate that to immunohistochemistry. We can do, if every case is getting 20 immunostains, that's four cases will be 80 slides. The Comet platform can do 4 slides. So already you're matching what you're doing on the current auto stainer. Okay, if it's you've got an 80 slide capacity and you're doing 4 slides on the Comet, that's equivalent. Okay, so that's one thing. It streamlines laboratory processes because they're only cut in one section. They're not treating each patient in a bespoke fashion. But this is where the real killer thing is as well. More 70% of the immunohistochemistry in a big lab like the QE is haematopathology because we order so many stains. So if you could take the haematopathology workload, put it onto these multiplex machines, then that frees up the workload on your standard immunostains to get through all the other, the P16s, the P53s, or cytokeratins that you want to do. So if anything, it's going to streamline, I think, laboratories by having your haematopathology done on these autostainers, and then the rest of the immunohistochemistry done on the chromogenic stainers as well. So hope that answers the question in terms of workflows. But
thank you. Buzz, do you have anything else to say on that? Sorry.
Oh no, it would just be interesting to see figures produced along those lines, because you also have to think we don't. If there is multiomics machines as you described, that's great. But most labs in the NHS are struggling with even physical space for these machines. It's good to have this in practice, but I think sometimes when developing what you deem to be best practice, if it's not broadly applicable to most departments, it will never be taken up, unless you're talking about large centralization, which within itself has kind of got its own downsides. But I think having a better conversation around what would actually work for as many places is probably more beneficial than simply saying health economics costings is this. Because in practice, even if somebody gave us the money, we still wouldn't be able to do what you describe. And I think there's been one of the concerns I've had has been some of the centres which are Haempath diagnostic centres. They've gone across this kind of battery where they've done huge genetic, molecular, and immuno testing on every single sample, nearly to build the data sets you describe. But many centres where there's several centres I've trained that believe that's a complete waste of resources. Partly for the reason why I say it's just there's not enough space, time, and people to get the rest of the work through. But no, I think if the work that you do can infer and be brought back to a standard immuno H&E lab, that's probably going to gain the greatest benefit.
Yeah, no, absolutely. It can
work for us for free. That would be great.
I mean, the one thing to say about the Comet platform is fully automated, and I would say it's actually easier than a conventional immunoassay. You don't need any special skills to run it, even though it's doing some really advanced chemistry. It's just a black box. You put your slide on, and it does it and spits out an image at the end. There's no need for someone to take the slide away, then scan it. They can throw it in the bin. The image is collated, and so for example, if you had one in a small hospital, it wouldn't need any additional skill than beyond what the current biomedical scientists have. In fact, there's less skill. I can train an MSc student to run this machine probably in a day. It's not skill or labor intensive. It's completely automated, and it churns out the data, and then the data could be sent from North Wales or Bangor down to a diagnostic centre without any hands-on labor really from the diagnostic lab. So you're right. These things need to be calculated and demonstrated before they'll be adopted in the NHS. But I'm convinced they'll actually bring efficiencies even to smaller labs, and it does not need any specialist skill set in order to run the assay.
Fantastic. Well, I think with that,
thank you.
Fab. I think with that we'll draw the seminar to a close then.
Yes.
So yeah, thanks again. Thank you very much.
Thanks for having me. Appreciate it.